Hello everyone, and welcome to my presentation of my PhD thesis called Design for Learning and Knowing Nurses in Chronic Care Patient Self-Monitoring Data. First, I just wanted to quickly introduce myself. My name is Katka Černá, and I have gained my PhD in pedagogy at the University of Gothenburg. Currently, I'm working as a postdoc in aging in IT at the University of Siegen in Germany. And the communities and fields I'm interested in are CSCW, HCI, and the keywords I am interested in are learning, aging, and nursing. First, I'm going to be talking about self-monitoring data a lot. That's why I'm going to first explain to you what does it actually mean in my thesis and how do I define it. So self-monitoring data are data that are collected on a continuous basis, which is different from other types of data in healthcare, which is often collected episodically or only at certain points. The self-monitoring data you can collect on every day. Furthermore, it's data collected by patients. So again, in contrast, normally healthcare data are collected by healthcare professionals. In contrast to other healthcare data, self-monitoring data can be also connected a wide range. So instead of only one variable, you can actually collect a series of them and look at them together. And finally, in contrast to other tools in healthcare, which are often based on paper, self-monitoring data needs to be produced by tools that are digital. What was the actual motivation for me to write my thesis? We know that healthcare is facing many challenges today. The population is growing, aging, there's more and people who actually suffer from chronic diseases. At the same time, the healthcare experiences shortage of medical and personal and finances resources. One of the solutions to these kind of challenges that is frequently lifted up as the one that can maybe help us overcome all these problems is use self-monitoring data. There is pretty big hype around this kind of data that patients can collect themselves on the continuous basis, and that's why many of healthcare professionals are expected to start using this kind of data in their work. The nursing profession then is the one that we expect to be engaging with this kind of data the most, because they are the ones who closest work with the patients and who often take care of communication and gathering and sharing data of the patient. But we also know that when a new tool is introduced, it is going to lead to changes in the way work is done. That's why in my thesis I argue that having possibility to access patient self-monitoring data will change the nurse's work. And more specifically, I decided to focus on nurses' work practice when a mobile application supporting patients in collecting self-monitoring data was co-designed and introduced into the nurses' work practice. And the aim of the thesis was to investigate specifically the nurses' learning and knowing when these changes started taking place. My thesis has been then divided into three sections, you can think of it. In the first part, I focused on the nurses' work. I tried to understand the strategies they use to support patients' learning of their self-management. In the second part, I focused on what happens when the nurses actually take part in the participatory design of the tool that they will be using later on. And finally, I also looked at and studied what actually happens when the nurses gain access to the self-monitoring data of their patients, and what kind of consequences there are for when they start using this kind of data in their work. So to be able to answer my main question, I chose the method of design ethnography. Now, design ethnography is maybe not so common term. That's why I'm going to explain to you what it actually meant for me and also why I chose it. In design fields, today ethnography is quite common. Maybe we would rather call it ethnography approach or approach informed by ethnography. but it means a little bit something different than a traditional ethnography, which is common, for example, in educational studies, anthropology, or sociology. What my approach had in common with traditional ethnography was definitely the long-term engagement. I spent 4 years working with the nurses and in kind of interacting and engaging with the field. I also tried understanding and making sense of how the nurses make sense of their work, of the data, of the working with patients. And I also used a range of qualitative methods to understand the nurses' work. So I conducted qualitative and quantitative observations when taking field notes and following, shadowing the nurses during their work when they were talking to patients or documenting the patient status. I observed both the practice but also the design of the mobile application that you will hear about later on. I conducted formal interviews, conducted workshops, but also spent a lot of time engaging in informal interaction. So chatting with the nurses, having lunches with them, and in general, trying to build up relationship. I think this is one of the key parts of ethnography, that this is what it's about. However, the difference in contrast to the traditional ethnography, I also contributed to the changes that the practice was actually going through. In traditional ethnography, you try to understand how things are. Meanwhile, in design, we try to understand how things should be, which stands in strong contrast to each other. At the same time, because I was also contributing to the design process, I was switching between these two roles. In addition, I would also say that I spend the time in the field a bit differently. Even though I did conduct observation studies, they would be only maybe several weeks long, in contrast to traditional ethnography when you would spend time, maybe a year, interacting and really observing people on a daily basis. I conducted my study in collaboration or in project that is called Efter Cancer, which means after cancer. That is an interdisciplinary project that connects the work of researchers from the education, applied ID, information systems, and clinicians from the hospital, as well as practitioners and epidemiologists. The aim of the project is to improve lives of cancer survivors who would receive radiation in the pelvic area, and now they suffer from symptoms or manifestations, as we call them, caused by cancer treatment. There were 3 nurses working in the center who would get in touch with patients and who were leading this kind of clinic. The pelvic cancer rehabilitation care, which is the term that this is how we would label the way the nurses were working, builds on the continuous contact between nurses and patients. Nurse would advise the patient on what to do and teach them how to handle their problems they are experiencing. The late effects of pelvic radiation, which is the formal term for the health problems that the patients or the cancer survivors will be experiencing, is a form of chronic disease. The people are going to have it for the rest of their lives, and they need a highly individualized and tailored treatment to their problems. So you can imagine a little bit better of how it looked like. This is a picture of the workplace of the nurse. In contrast to maybe what we imagine as a nurse works in a hospital, the main workplace of the nurses I have been working with is a table where she sits and either make phone calls with the patients or makes documentation on computer and writes down her notes. And when she meets up with patients, this is how it looks like. The nurse usually sits on the left, the patient on the right, and they talk to each other and chat with each other. During the first observation study that I conducted when I was trying to understand how the nurses work and how they support patient self-management, we identified a problem that they were continuously having, and that is that they needed to know the answer to this question: how often did you pee last week? In overall, this was a common problem because they needed to know how often, how frequent certain symptoms happen to the patients. And to be able to answer a question like this, it's very difficult because it's the chronic disease experience is very multifaceted and it's difficult to remember it. That is why we have decided with our research team to build a mobile application that will help the nurses to overcome this problem and provide them with more precise information that they can then meaningfully use in their practice. The design of the mobile application was organized in line with principle of participatory design and a sustainable approach. Participatory design, it's an approach when people who will be actually later using the tool are involved in the design process. That was a bit different for the nurses and the patients, even though both of them were involved in the design process. As you can see in the table, we have first started with meeting only the nurses, and the patients were then invited into the design process later. The reason for this is that even though it is the patients who are the end users, they are the ones who are actually interacting with the mobile application on a daily basis. However, the application is primarily a clinical tool. That means that it is the nurses' knowledge needs. What is it that they need to know? That is the thing that the mobile application should provide them with. Hence, we started with them. I urge you to go more in detail and look at the table on the type of activities that we did. But I think the most important thing that I would like to lift up right now is the sustainable approach. So even though the first maybe 5 or 6 design activities took place in just meeting rooms, and we were discussing prototypes and testing different prototypes on spot. Later, we also have the nurses actually use the prototype. Now, this is really important part because we know that to be able to design a tool that will be actually meaningful for the given practice, we need to not only evaluate it during this product development phase, but also try to understand it later on when it's actually being used in practice. That is going to provide us not only with better product or final product, but also with a better understanding of how the practice was actually changed. And this is something that my third study was also focusing on. During the actual use, we could see that we not only need to adapt the application, but also we need to focus on how the nursing practice actually changes and what kind of consequences that can have, both for the nurses but also for the tool. So this is just a picture from the design process, so you can imagine how it looks like. On the left side, it's the nurse making very strong gesture, and on the right side, it's one of the researchers from applied IT, and in the back, it's a developer observing what's happening during the situation. And this is how one of the later prototypes of the application actually looked like. The application involved a series of questions that the patients would answer. There were 2 ways how the patients could answer the questions. On one side, there was a daily form that the patients were supposed to fill in at the end of every day. And at the same time, there was so-called experiential sampling survey, which is a set of questions that you answer when a certain problem is taking place, and then you can fill it in right after. So for example, when patients would experience pain, they would go in the app and fill it in, or when they would go to the bathroom, which was a very important thing for the nurses to know. And this is how the nurses could then view the data that the patients would collect. These squares or these boxes could have been extended to graphs, and the nurses could look at it over time and how the symptoms were changing over time. As I said before, it's important not only to focus on the development of the product and then just let the users use it however they want, but it's also important to understand when you develop something, how does it actually fit and how is it being used in actual practice? So what we have seen, or what I have seen in my studies, is that the kind of core competence of the talk changes when the self-monitoring data and the application is introduced to the talk. The In the traditional talk, when the nurse didn't have the application, she had to be really good in eliciting these estimates of how the patient experiences their problem. And at the same time, the patient had to be really good in describing of their problem. Now, these elements were left a little bit when the application was introduced into the talk. And what became important instead is that the nurse can not only read graphs, but can also support the patient in using the mobile application, as well as be able to interpret data in the given context of the particular patient. And on the side of the patient suddenly became more responsible because they themselves had to be able to recognize when is the time to actually report the data. And also they had to be able to communicate to the nurse how exactly they were using the application, because this was a crucial information that the nurse needed to be able to interpret the data in a meaningful way. Now, all these findings, we wouldn't be able to learn about them if we didn't actually try to focus on the nurse's work and how it changed. And we have learned some very important insights for the design of the application. Just quickly, the implications for nurses from my thesis. We know, or what my findings indicate, is there is a need to change the education of nurses, and so that nurses know how to use self-monitoring data in a meaningful way in their work, as well as there are indications that being involved in the design process is beneficial to the nurses, and it can help them to develop new competencies that they can use later on when dealing with a new tool that's being designed for them. If you're curious more about this and about more implications for nurses' work, I recommend you to go to my thesis and check out the implication section, because that's where I talk about it more. And that was all for me. Thank you for your attention.